watching the video, it probably took 2 minutes for that IV to be put in. Whereas if I'd open up a cannulation pack and grab my 20 gauge, I would hope in a good vessel it might be in 30, 40, 50 seconds.
When on the video, when was our patient cuffed behind and put in the lateral? Do you know, around the
10 minutes, 11 minutes, somewhere around there.
Yeah, so it was around.
And then I then went into the head once I felt it was safe for me to get in. You know, and again, I was just trying to have situational control. That he was still, kicking his feet and everything else when I came into the head.
Yeah.
And that's when I kind of went to Courtney. Right, I want you to get my resuscitate. I want my BVM set up. I want my airway kit open. Sal, I want you to turn the monitor on. I want nasal on. I want this on if I get to this point, but it's over there if we get to that point.
Yeah.
And I was tasked on that, and that was sort of out of sight. And I think that was around the 10 or 11 minute mark.
So,
and then my assessments started occurring about the 12 minute mark, and I dutifully recognised, as I've already said, that the BGL could have been swapped in for where my ECG was performed, but the CPM still has the ECG on that assessment criteria. That could have been swapped around when it came to value, and then I labelled, right, you just got a low, right, Sal, I want you to do an IV. Courtney, can you prepare my glucose?
Yeah.
Are you competent, or have you done that, or can you do that?
No,
and she went, no.
I thought that was good. And we actually mentioned that in that feedback. You'll see you're actually doing that better, where you're going, Luke, can I ask you to do this, and Gavin do this, and then all of a sudden you're going, you're seeing that Luke's having trouble, or Luke can't do it, and then you straight away starting to recognise and going, look, I might just swap you out, I might get you to do this, and Gavin, you to do this. And we acknowledge that.
I just think, for me, I label I was going to be the airway support person outside with my brief, the QAS guys, and that was off camera and outside, sadly. And I delegated that role was for me to be able to have the oversight, to have the view, to have what is potentially going to be with sedation. The most risky complication of sedation is the loss of the airway.
Change.
That's where I want to be. And then when I was sort of sitting there and it floated into my mind when the cannula was taking 2 minutes or 2.5 minutes to be performed, I still found myself going, we've got a obtunded sedated patient. That is still hypo, yes, that's a major concern, but my airway is still a major risk, and I wanted to be there rather than tasking that to someone else.
And to come back to like a discussion that we have sometimes around seizures, what's your best management for an airway in a patient who's seizing?
Like going NPA.
Yeah, stop the seizure.
Oh, yeah.
Let them maintain their own airway.
So what's best management for
I wouldn't be putting an airway in someone that's actively seizing, though.
Yeah, but I guess part of that consideration is
part of your airway management.
We've had a patient pathway that's gone from angry, stroppy, sitting in a chair, hopping up, purposeful movements working towards you, being restrained on the ground, then starting to make robot noises and bizarre utterings.
That's a red flag.
Then going to slurring of words, and then going to
nothing.
ALOC, GCS3, and then the pathway up from there. So for mine, it's like this isn't a patient who's maintained purposeful lashing out, screaming on the ground. They've started doing weird stuff. And for mine, that's if the system's in there, is there pointed to an ability to look for a reversible cause earlier? Is this person hypoglycemic? And is there, even if our patient's prone on the back, access to a finger where we can get a VGL?
See, I didn't feel comfortable sending the girls into an environment where the feet were still going. I just went, no, I don't. I've got a single police officer providing restraint. I didn't feel comfortable with that. But the girls trying to be the clinical leader with their safety, and there was probably at least 5 minutes or whatever where they were out of camera where the TV is. Yeah. We got to the lateral at 10 minutes, but it wasn't until I sort of saw myself at a 0 that I was ever going to feel comfortable in sending my team into...
Can I say something, Ben? From an ABD perspective, once you've seen excited delirium a couple of times, you'll always remember them. Then you'll remember these fat criteria of ABD patients that are alcohol, methamphetamines, ecstasy, whatever it is. And then you'll you'll definitely see the ABD patients as a result of organic, especially like UTI, for example, or certainly the hypoglycemic ones, and quite often more than not, they're diaphoretic, pale, and they're not just aggressive and either ranting and raving. Their thought process is so uncoordinated, and sometimes their muscle actions are uncoordinated, and you've seen hypoglycemic patients. You know what I mean? You've probably seen some agitated hypoglycemic patients, and
Never an agitated one.
13 years, you've never seen an agitated hypoglycemic patient.
No.
I know. Well,
My hypoglycemic cases are subdued and obtunded.
oh, okay.
And I walk in and I complete my assessment and go, there's the hypo, and I treat it.
Okay. Oh.
And that's where, even to the end, when I was trying to do
Maybe-
that
maybe-
reassurance and that conversation,
maybe-
they were coming out the other side, because obviously
Yeah.
the last thing they lose is their hearing, the first thing they
Well,
gain is
maybe-
their hearing. I
maybe-
was trying to talk him out of it.
Maybe
gently.
some learning tonight. Google agitated hypoglycemic patients, and Google, agitated patients on methamphetamine, and just have a watch. You know what I mean? But what I'm saying is, sometimes you think of the safety of the young crew you've got, definitely, but it might be get a BSL, come from behind the patient that we've told you before. He's cuffed with his hands. Quick BSL, really early on the sim for that one, that you could look at, and then go, this BSL's low. All right, okay, right, and then you can walk over to the girls. Go, the plan is have the IV set up. Actually, I might do the IV. Have the glucose ready to go. As soon as I've got the IV, let's get these glucose in, and then you change. You're sort of changing your plan. You know what I mean? Like, you've given the droperidol. You don't think this is definitely totally drug related, or psychosis. They're not mad, bad, or sad. It's organic. You know what I mean? I'm sure
If we come back to the systems, just to get us back on track to where we're at here, with the systems there was some late assessments in the piece there, and you've stated that you did the assessment when you felt safe to do so. The feedback from us is there may have been opportunity to do that earlier on in the picture, and if you had have done that earlier in the picture, then it would have given you more of the jigsaw pieces that you would have put together. So if you identified when this patient's, being able to be put in the lateral position, a BGL that's lower, then you're 2 minutes or 3 minutes ahead of the, all right, where are we at? What do we need to focus on in this setting? Do you...
For me, safety comes first. Myself, I want to go home at the end of my shift.
Yeah.
For me. I've had 2 incidents now where I've been physically assaulted at work. So for me, you might be having a hypo. I respect that, but I come first, not you.
Yeah.
So whether that just be a reflection of what's coming out in the sim or what, I don't know. But for me, it's just that until we get to that point that I feel safe, we're not doing it.
So
facilitators, we can't argue against that. You just can't argue against that. One safety first. But what we can say is, from experience, even with one copper, whether she's tased him or sprayed him, whatever she's done, she's got him to the ground, she's got him cuffed behind his back. He especially with a hypoglycemic patient, she's got control of him. Okay, what we're saying is, come in from behind with the cuffed hands, you probably could have got a BSL. And I would have safely done that and had my hand on my heart, knowing. Now, I can tell you now that I have been kicked in the testicles, put me in hospital for a night, and off work for a week. I know what the feet are like. I learnt that very early 20 years ago. So I know what it's like to be severely assaulted, and I wouldn't have got assaulted.
So in terms of expected pathway, you perform your sedation and safety, you've given droperidol. You've absolutely done that. You've identified,
that was good.
In the first instance, this is unsafe. Once the patients are restrained, I can come in and give the droperidol. The second part of that sim is to identify early on a reversible cause after sedation and restraint has taken place, and then treat with glucagon or glucose 10%. In terms of the expected pathway adjustments, expectation is for glucose to be provided within 15 minutes. we're outside of that. And I think we're outside of that because of there was opportunity to buy some time within that SIM. Now you're stating that you didn't feel like that because of an ongoing safety issue within that setting. I guess we're in this strange mix now where we're sitting back and going, well, on review we've looked at it and we think there was an opportunity to do a BGO.
So at the same time, like I've got a single police officer. If I had 2 police officers, and I had one on the chest side and one on the back side, I've got suitable physical restraint on my patient if they're at a SAT +1 or a little bit of a SAT +2. I'd probably feel a little bit safer and going, right, I might go around the back where I can feel safe, but I've got physical restraint on the front side.
So if we threw another police officer in the mix,
I think I would have considered it.
Yeah.
I would have considered it. But, you know, to have someone that's physically restrained and mechanically restrained, so cuffs in person, they're at the back, where they, you know, Nat even said, I feel safer to roll this guy laterally as you're asking, I'm going to be behind them. Now, she verbalised that. But to then go and move someone where they're providing the physical restraint, to move someone, you've got to release that. And you open up. So you're holding something down. You've got all your force holding something down, or 80% of your mechanical force holding someone down. To then move your body, you're shifting your amount of force applied to that person.
We might have a look again because I'd like to have a look again. Like seriously, you've said that.
I've had in Mount Isa, you talk to Westy, Matt Steer, in Mount Isa quite often the Indigenous are quite a sick population, and we've had ABD where the guys are on drugs and alcohol usually, and they are we've had a few that are hypoglycemic. And we've come in from behind with minimal resources. You'll say to the police officer and go, have you got this patient restrained? And you're going to weigh up the size of the policeman to the size of your patient and what their condition is at that stage as well. And I've come in from behind while they're cuffing back and just put a tourniquet on, see what happens. You've seen veins pop up, you know what I mean? You can safely get in there and cannulate, and they're not going to even move. That's even cannulate with them, with their hands behind their back. And then we've taken control of these guys. And this is even before, you know, we were giving droperidol. We're looking at IM or IV Medaz back then, you know, so.
I don't want you get the message of we're telling you to compromise your safety. That's certainly not the case. I think we should look at the video again just to see what the patient's disposition and muscle status was, and when they were rolled onto the side, what that timing was, and on review, if we both look at it at the same time, whether there was opportunity for an assessment to occur.
The first thing I can see in your order of priority in your vital signs assessment, the BGO could have been moved up. I'll be the first to say that. Right? And I put the O2 on, I put my end-tidal on with the sedation type thing in the back of my mind. Let's get a temperature, let's get some ECG on as it states, and the BGO could have been slid up before the temperature even.
But we were sitting back and like I guess I was waiting for it to go, how this would run in a perfect situation would be sedation occurs, patient's position lateral, assessment done, rapidly identification of hypoglycemia, and when appropriate to do so, cannulate, start the fluids. Achieved within 15 minutes, that's an assisted to independent case. The way that it ran in this circumstance,
16 minutes or whatever,
it wasn't achieved within that time frame. However, the thing that's going to prompt you so that you know the order, or you don't forget the assessment items or your vital sign things, or the things that need to be done within your brief and within your setting, is your checklist. And for mine, that's if we're setting up our SIM with an airway kit open, or our oxygen open and BVM ready to go, that's something that should be out just to gives you the prompts. You can look down and go, right, I've done my assessment there, I need to get my full set of vital signs, I need to remember SpO2, ECG, I also need to remember temp, I need to remember BGL, so that we order and we get to it as quickly as we can. Next one through was interpretation of vital signs investigations.
As soon as I've done them, I don't think there was an issue with that at all.
Yeah, we've agreed we've given it at the assisted level,
Mm,
but that's at standard. Yeah. Development of working differential diagnosis.
I marked that as independent. I worked my way through. It was an ABD behaviour that wasn't normal when I walked in. I labelled that and initiated treatment. And then when I completed my assessment, I found the differential and I treated that.
We've reviewed that as dependent for the reasons given previously. While the ABD is the first priority to control safety of yourself and the patient and the QPS officer on scene, a recognition or a development of a provisional down to this could be an organic and we need to check for the organic early within that setting, that flows on with the opportunity to do so. Probably just push that from are we dealing with the purely ABD of a behavioural or behavioural nature? Is this person acting out because they're angry with the world and wanting to, bash and smash around them? Or are they angry because they're hypoglycemic and that there's a reversal process that we can put into play there? And then some of the management planning from there kind of works through the management planning and implementation is a little bit slow because of that in the perception, the review of the case there. Having a look, there looks like there's just a difference in the way that SIM was reviewed by yourself and by us. How'd you go overall?
I would have marked myself at an assisted level, but listening to the feedback, I know it's not.
So
my biggest concern with that was, well, I guess in the early stages, the loss felt as though I lost control of the QPS. I thought that my communication with the ACP team, I thought my communication with the copper of my expected clinical pathway. I spoke about I had my second agent drawn up. I had I had my second dose drawn up. I had a second agent available if I needed to. So I briefed them of that. I reminded them a few times that I respectfully acknowledge that you're a single officer, but I don't want pressure on the back. I don't want pressure on the head and the neck. Where possible, I want you to release that and do that. And I think I reminded her on one occasion after I labelled that. I thought my communication was good. I thought that my demeanour and my professionalism again were very controlled. I felt in control in that SIM. I didn't feel like the second one yesterday where I felt flustered. It might not have come across that way, but I felt that way. My risk benefit, I thought that was assisted. I recognised that I was sedating someone and needed to have the airway stuff ready for the risk there, but then there's a benefit in that it's got to be protection of safety for us. My troubleshooting, it was a situation of recognising my student didn't feel competent in that skill, and I swapped them. And then when she was doing the IV, I got the information that the veins average to poor. I labelled to her, I want you to look. What do you see? What have you got? Do you feel competent in doing that? Sarah gave me the prompt that she can do the skill, she's done the skill under supervision. I felt myself at the head, I can provide that supervision as she was doing that skill. Watching the video, it took 2 minutes or 2.5 minutes to perform the skill. And at that instantaneous time, and when I was watching the video, I felt myself going, I could do that quicker. But I also reflected that where I am here, I'm at, to me, the riskiest part, the airway, with sedation. But from here, I can also have that oversight. I wasn't like my asthma one yesterday, drawing up mag and everything else, and peripherally I could see things going on, but I didn't have the direct view of what was going on. So, the best situation, I would have been a full crew and there was 4 QAS there, and I could have literally stood at the feet or stood at the hand, do this, do that, do this. You're having trouble, right, I'm going to quickly step in and do that, and then I'm going to come back out again.
Ben, if you're at the airway and at the head, and that was the best position to be in, how did you manage the airway? Overall, from being unsafe to independent, how do you think you managed the airway on that case?
Assisted.
Okay.
I had them in the lateral position, I had there, I was able to put the head in the sniffing position. The only time I felt that was poor was when I went, right, I've got to put an O2 mask on, and I couldn't get that right, and at one point I had to let the head go down to get it right. I heard